4 years ago, I started an investigation. I wanted to find out why every year at renewal time, my company faces double-digit increases in healthcare premiums. Let's consider healthcare expenditures at MCS, where I am CEO. In 2018, a family plan cost over $27,000 a year. That's $13.50 an hour for one employee with a family. MCS and its employees spent $2.6 million for health care coverage. That's 22% of payroll in 2018. So I took a deep dive into the healthcare insurance industry in the United States, and I didn't like what I found. 155 million Americans receive healthcare coverage through commercial insurance negotiated by their employers. Another 20 million Americans buy commercial insurance on their own. Our healthcare system's reliance on private insurers is the principal reason Americans pay twice as much for healthcare compared to the rest of the world. The result is a huge waste of money and also poor population health. Each year, 600,000 Americans file for personal bankruptcy due to medical bills, most of them having some form of insurance. The system is clearly beyond the economic tipping point. How can we get healthcare on the right track, providing comprehensive benefits to all while at the same time reducing cost? There's a simple solution. It's called Medicare for All. And how do we pay for Medicare for All? The fix is conceptually simple. We adopt Medicare as the insurer for all Americans. We simplify, as other countries have done, the administration of the system by eliminating the expensive middlemen like insurance companies and pharmacy benefit managers that cost us dearly but add little value. We negotiate reasonable prices available internationally for drugs and devices and for medical services under Medicare. We implement a public financing plan that fills in the financial gap created by ending our reliance on insurance companies. To administer MCS's plan, our insurance company takes 17 cents of every premium dollar for overhead. Traditional Medicare takes only 2 cents of each dollar to administer its programs. That's 2 cents versus 17 cents. In addition to their own overhead waste, commercial insurers also cause massive administrative waste at the provider level. Running a hospital in the United States is a bureaucratic nightmare. Many hospitals have one billing person for each bed to handle complex insurance requirements. Doctors and nurses waste hours negotiating with insurers on which treatments are covered and why they are needed. We can save 7 cents of each premium dollar on provider administration with Medicare for All. We all know that pharmaceutical prices in the United States are out of control. We have employees on medications that cost more than their annual salaries. Americans on average pay twice as much for drugs compared to other advanced countries. Medicare for All will establish a regulatory framework to bring down prices to international levels, and that will save 6 cents of each premium dollar we now pay at MCS. U.S. hospitals have regional monopoly pricing power over commercial insurance companies. Medicare does a better job controlling cost by negotiating lower prices for hospital and doctor services. The Commonwealth of Pennsylvania publishes an annual report on hospital economics. It shows that a day in a Pennsylvania hospital under Medicare cost half the amount paid by commercial insurers. Looking at hospital payments across the country, the Congressional Budget Office had similar findings. When we add up all the savings from reducing waste and lowering cost, 41 cents of every MCS premium dollar can be saved with Medicare for All. Our goal is more than just a reduction in cost. The billions of dollars in savings will finance an expansion of coverage to all Americans. As we end our current system's reliance on high insurance premiums, we will use less expensive Medicare payroll deductions to fill the financial gap. Medicare for All will be a tremendous savings for my company and particularly to its hourly employees. For the vast majority of our employees, take-home pay will increase dramatically as premium sharing declines. Overall, MCS's healthcare expense was 22% of payroll in 2018. That's 22% versus the projected 8.2% as a payroll deduction that Dr. Gerald Friedman projects in his plan to finance Medicare for All. Dr. Gerald Friedman is highly regarded for his economic impact studies on single payer for individual states. He has produced a detailed national model demonstrating how Medicare for All can be publicly financed.
I've been at this for a while, studying the relative efficiency of alternative healthcare finance systems. A great many research institutions have weighed in, and all have concluded that a single-payer system would save money while extending coverage. Just in the last year, Rand Corporation modeled single-payer systems for 2 states, Oregon and New York, and found significant savings even after taking account of the cost of covering the uninsured and improving coverage for the underinsured. While the projected savings vary depending on the assumptions made, even the most conservative studies project that a publicly financed universal health insurance program would save money while providing greater access to needed care. A simple comparison of healthcare spending in the United States with spending in countries with publicly financed systems shows we spend almost twice the average of nations within the Organization of Economic Cooperation and Development. All of these countries spend less but have better health outcomes. Compared with us, the Brits live nearly 3 years longer, the Canadians over 3 years longer, the French 4 years longer, and the Swiss 5 years longer. We waste money at every stage of the healthcare system. Private insurance companies, for example, take in premiums of $1.3 trillion and keep $260 billion, 20% for their own administration and profit. By comparison, Medicare provides traditional benefits of around $500 billion, but only $8 billion is spent on administration, or 2%. It achieves these savings by paying lower managerial salaries, avoiding 8-figure CEO pay, avoiding most marketing expenses, and by not profiting from our health care. The 18 percentage point difference in administrative bloat comes to over $230 billion. We also waste money because it's expensive for providers to process bills for multiple insurance plans. U.S. hospitals and physician offices spend 20% of their revenue on administration, nearly twice as much as do their counterparts in Canada. This is $200 billion wasted billing a fragmented private insurance system, waste that disappears with Medicare for All. Americans pay too much for health care because a few drug companies and massive hospital combinations use monopoly power to drive up prices. If we all paid only what the Veterans Administration pays for drugs, we would save over $200 billion. If we all paid only what Medicare pays for hospital and physician services, then we'd save $400 billion. Monopoly pricing by drug companies and hospital networks account for nearly half of the gap between what we pay for health care and what everyone else in the world pays. So even if we accept the most conservative assumptions, we are still projecting savings almost as great as the current Pentagon budget. Nearly 8% of Americans still do not have health insurance. Universal coverage would add another $70 billion for their additional health care. Many Americans with health insurance find that coverage does not allow them to see doctors when sick or to fill prescriptions because of punitive copays or high deductibles. Using estimates from the Centers for Medicare and Medicaid Statistics, I project that spending may increase by as much as 7.4%, a cost of nearly $200 billion, when we allow people to see doctors when sick or to fill prescriptions. This extra spending should not be regarded as a cost because it means we are providing adequate health care to Americans, lowering the rate of morbidity and mortality and raising well-being. When we say that it is time for a change, the standard response is that it would take intolerable tax increases to fund a public program. There's something fundamentally wrong with this argument, because if Medicare for All is less expensive than the current system, then Americans will be paying less in new taxes than we pay now for private funding. Regardless of how we collect the money, we will be spending less. We are already paying most of what we need for a better healthcare system in Medicare, Medicaid, tax subsidies for employer-provided health insurance, Affordable Care Act exchange subsidies, S-CHIP, and other programs. There are many ways that we could collect the remaining revenue needed for Medicare for All. A moderate plan would pay for Medicare for All by mimicking the way we pay for Social Security now. There would be a payroll tax of 8.2% for incomes above $25,000, a 5% levy against dividend and capital gains income, and premiums to those without labor income and above twice the poverty line. While there are many ways that we can fund Medicare for All, they all share this. If we can pay for the status quo, we can pay for a program that is less expensive. The question is not, can we pay for a more efficient system that would provide better health care? The question is, what is stopping us?